Hello again.
Hello. Hello.
Hi there.
Hey, here we go again.
That's right.
When is this coming out? Connections.
Hopefully next month. Should be next month.
Oh, okay, that's good. Right before graduation then?
Yeah. Well, right sometime next month.
Oh, that's right. I forget it's closer than anything. Oh, okay. Let's roll on that one. Is it still, it's not printed, right? Still gonna be
All
digital.
digital. It's all digital.
Oh, okay. That's good then. Perfect. All right. Do you need me to pull anything? I know what you're recording this stuff. Do we need to pull any information or?
Nah,
Okay.
pretty generic.
Okay. Gotcha. All right. Who's making oh, hey.
Hello, John.
Hi, John.
Hello, Matt. Hello, Anita.
How you
Hello.
doing? Long time no see.
Doing pretty well, staying busy.
All
How about
right.
you?
All about the same. Always busy. Hey, thanks for joining the call today. The reason we wanted to talk with you and others is just to find out some more about the research that you're currently working on, some of the goals of it, what maybe early findings, or and use that information for an article in our alumni magazine Connections. So, John, what are you up to?
Well, like I said, a lot. I've got two big projects and one small project that, even though it's small, I'm kind of excited about.
Well, tell me about them.
All right. So the first big project is a clinical trial looking to improve care for older adults with dementia in nursing homes.
Are you working with Nancy at all in this project?
I am not working with Nancy on
Okay.
this project.
We interviewed her earlier today, and it was kind of the same topic.
Mm-hmm.
Sure, we have a lot of overlapping interests. And we haven't done any major collaborations together, but we work together on a lot of different committees and with students. So
Okay.
fair amount of cross-fertilization going on there.
All right. So tell me more about this first project, the clinical trial.
So this clinical trial is designed to evaluate whether a model of care using a palliative care approach improves quality of life and quality of care for patients in long-term dementia care in nursing homes. We are conducting this in 8 nursing homes in Maryland and 8 nursing homes in Indiana. And we're implementing this model of care, which uses a consultation approach. Basically, we go in, educate members of the existing staff. We identify 2 people who are willing to serve as kind of internal champions within the nursing home to implement palliative care principles. And also we connect them with an outside palliative care expert. And so if a patient who has cognitive impairment, likely dementia, is struggling with burdensome symptoms that can't be resolved, typically the internal folks will go in and do their best to resolve the issue. And if they're struggling to provide relief, then they can contact the outside consultant to come in and address whatever symptoms are going on. At least another set of eyes and ears, a second opinion, somebody who's got strong expertise in the field. And so we're using this partnership between the nursing homes and these external consultants to, like I said, improve the quality of life and quality of care for these older adults with a dementia diagnosis in long-term care. And historically, we've really struggled with providing good care for that group of individuals.
And how long is this study and who is funding it?
This is a 5-year R01 project funded by the National Institute on Aging, which is under the NIH umbrella.
Okay, and any early findings of what you're seeing? Any?
Well, early findings. So we don't have any early outcomes yet to really provide indication of how the intervention is going, but we do have findings looking at what quality of life and quality of care currently look like in nursing homes. And it looks like a lot of residents who have dementia are struggling with agitation, with ability to swallow. We're also finding that a lot of residents do not have good family support. And so we've been struggling to connect with families, get their opinions on quality of life, quality of care. And typically the intervention is designed to address not only the residents' care concerns, but also to help support the family members that are often providing their own kind of support. And in past projects, I found that if we do a better job of educating and supporting family members, that the patients end up getting better care.
Okay, great. What's the second thing you're working on?
So the second big project is a collaboration with Hopkins, and this is another R01 5-year clinical trial focused on dementia care. And this is really looking at earlier in the dementia care continuum. So we're looking at working with families who are still receiving primary care. And so they're still going to clinics, typically living at home. We're looking at older adults. And the purpose of this project is to see if having conversations early in the dementia trajectory improves end-of-life outcomes. And these conversations are conversations about goals of care, advanced directives. And so these are advanced care planning type conversations, basically to find out what people want in terms of care later in life, and if they have a good sense of what the options are, and at the very least, if they can't make decisions for themselves, who do they want making decisions on their behalf? And so that's really important when you've got people who have a progressive illness that will very likely eventually hinder their capacity to make decisions.
And who's funding this?
This is also National Institute on Aging.
Okay. How far into the study are you for the 5-year study?
So we are just entering the 5th year on this study. And the initial big project I was talking about, we are just starting our 4th year.
Okay. What are you seeing?
From that project, we were surprised that people who have early signs of cognitive impairment can engage in conversations about future goals of care and preferences for care. It depends. So there is a bit of a spectrum. Some people have so much cognitive impairment that they really have limited capacity, but we are finding that generally people can provide at least some indication of the kinds of things that they would want or not want later on in their healthcare journey.
Okay, and then from the second study, I would think the goal would be to take this information and share it with these facilities nationwide.
That's right. We want to, first of all, share the findings with the facilities that participated in the project, and also share this information nationwide. Ideally, if we are seeing an uptick in the quality of life and quality of care due to the intervention, then this might end up being implemented on a national scale.
Are there policy implications with this research? Can it possibly dictate policy with Medicare and Medicaid and other funders of such long-term care?
Indeed, if we start seeing positive outcomes associated with either of these projects, then yes, the policy implications are pretty direct, and we might see Medicaid, Medicare support for these kinds of interventions.
Okay, that's great. And what about the third small project that you're excited about?
So this third project is designed to improve pain management in hospice care.
Okay.
So just a little reminder, hospice care is basically care for dying patients. People generally become eligible for hospice when they have a life expectancy of 6 months or less. And one of the things that hospice providers typically focus on is minimizing pain, providing comfort and relief. For example, if someone has advanced cancer is typically associated with high levels of pain. And so the hospice providers come in and provide expert pain and symptom management. Hospice is also designed to primarily be delivered at home. And so the typical hospice model of care is that the hospice care providers will come in and provide kind of the expert clinical support to the family members, maybe neighbors and friends that are helping to provide the care at home. And typically that's what people want, is to be surrounded by friends and family at home in their final days. And so hospice is designed to support that. One of the challenging things is that the family caregivers, they aren't typically medically trained. And so they feel very uncomfortable evaluating a patient for pain, dosing pain medicine. And if patients themselves are able to self-medicate and do their own care, quite often patients have concerns about taking pain medicines. Either they're worried about taking too much, overdose, or worried about becoming addicted. And especially with this larger national opioid epidemic in the backdrop, people are more sensitive to like opioids and narcotics, and they have more concerns. Anyway, we see that all of these concerns kind of converge and really hamper our ability to provide good pain relief for hospice patients. And so this little project that I'm really interested in is simply asking patients and families a series of questions. It's just 8 questions to see what their concerns are. And then if they have concerns, to address those specific concerns. One of the things I'm really excited about is this small project has been designed to translate the questions that we're asking into Spanish using a best practice approach. Experts who are familiar with both the healthcare environment and the Spanish language from different regions, not just from Mexico or Spain, but from a variety of Spanish-speaking regions, so that it's truly as generalizable as it can possibly be to a Spanish-speaking audience. And then to deliver those materials and basics about this intervention to the 200 hospices that are caring for the highest proportion of Hispanic patients in the country, and then getting their information about whether these materials are helpful. So really, the big picture here is to address disparities that we see in pain management among Hispanic patients, and more specifically, Spanish-speaking patients receiving hospice care, to make sure that their concerns about pain and symptom management are addressed so that they can experience relief in their final days.
On a somewhat related topic, I think several years ago, you did research on the pain meds and how they would kind of disappear from the people that they were designed for. Is there any update on that, or?
Sure. So we've got a lot of people took interest in that work, and so it's been picked up in a number of different areas. There's a group out in Chicago that's basically building off of what we did with hospices, and they are looking at understanding opioid diversion and misuse in nursing homes. And so they're trying to understand what's going on in that environment and building maybe some recommendations for long-term care communities to minimize misuse and diversion in that setting. We also have some policymakers in the hospice and palliative care community that are updating their own approach. In fact, the hospice pharmacy folks are using our guidelines to develop their own best practices for pharmacies who provide care for hospices. And so yeah, it's being, there's been a lot of interest in that work.
And this was the one where you did all the calls? From the
That's the
mini
one
call
where
center
we
you had?
yeah, where we had a little survey research call center out of the
My old office.
That's right. I forgot about that. We did use your old office.
Yeah.
And yeah, I've got a project, kind of a next step project brewing there, and we'll see if it gets grant funding. But my idea is that we will do, after a patient dies in hospice, we will pilot test having the hospice nurse go out and do one more additional visit after the death to make sure that medications are disposed of in the home. Because I don't know if you recall, but one of the key and kind of disturbing findings from that project was we found that when patients die, in roughly a third of households, the medications, often narcotics, are not disposed of. And since those were prescribed to a patient who's now dead, no one in the galaxy can legally use those meds, and so they're at very high risk for misuse. And so if we could just send out the trained hospice staff to go and dispose of those medications with one visit, then we can remove that source of potential risk and future addiction from those homes.
All right. Anita, what kind of questions do you have for John today, if any?
Oh, we covered quite a bit. I noticed that it's under the same theme. What do you hope to gain from all these different projects as you're kind of working with them simultaneously and in the field? Like, what do you want, I guess, overall, what people would you'll be able to share and maybe change in the field? Like, what is the goal? Because they all, pretty much in dementia, hospice care, family support services and all of that. So I just was curious, just overall general, like, because obviously this is not, you in this field, but then the connection between them is like the link. I guess that's my thing. And what do you want to come out of it? If that makes sense, sorry.
Yeah, so across all three of these projects,
Mhm.
My grand goal is to move the needle a little bit to improve the quality of life for people who are, at the very end of their lives. And so that's kind of the overlapping goal,
Mhm.
is that in nursing homes, I want to make sure that this group of vulnerable individuals is getting the best possible care. In the primary care setting, we want to have these early conversations so that their future healthcare preferences and wishes are honored, and so they're getting good care when they need it. And then in the hospice, addressing barriers to pain management and Spanish translation of measures project, that is also designed to, at the end of the day, improve the experience for that vulnerable population. So that's really it. Those
And-
people that are really sick and dying, I want to
Mhm.
just improve the care just a little bit on a large scale.
I was just gonna ask what drives you to do this? Why did hospice dementia
Mhm.
become a thing for you?
Well, I was a hospice social worker for 10 years, and so I've met thousands of dying patients and worked with families, and so I feel a connection and responsibility to the people that I worked with to just kind of push the field forward and make improvements. And also, in my own personal life, my two of my grandparents had hospice. A lot of my friends and family members, extended friends and family members, have received hospice care. And so, yes, if I could just do a few small things that make a little bit of a difference, and we can scale that up on a national level, then at the end of the day, I will reflect on my work and feel some level of satisfaction.
Oh, that's great. I mean, you're not doing a small thing. It sounds like you're doing a big thing. So
Mhm.
I'm sure there's thousands of people out there that have really appreciated your work, even though they don't know you did it. But is there anything that you wish we asked you? Anything else you'd want us to talk about in this article?
Um, Maybe one, you mentioned the looking at the project that looked at medication diversion in hospice.
Mhm.
I do, every time there's a bit of a spotlight focused on that project, while we did find that there is some diversion going on in hospice care, my concern is such that I don't want policies and restrictive regulations to hamper pain management practices in hospice. So, there's kind of this pendulum, making sure that patients have
Yeah.
ready access to opioids and narcotics. And, I want that. And, because of the opioid epidemic nationally, there's this tightening of restrictions,
Mhm.
and that has some negative consequences for patients who have legitimate pain, need relief, and their pharmacies aren't stocking these medications because of strict regulations, or they can't get enough of a supply at home um, in order to address the pain that they're experiencing. So I do just want to provide more of a balanced assessment that, on one hand, we want smart regulations that are designed to keep people who shouldn't have those medications safe, and so that, we're not seeing diversion. But on the other hand, we're making sure that the people who need access to those medications can get access to them. So
Okay, yeah, and you'll get an opportunity to take a look at this before it's published, so make sure that that is done in a way that you approve of. So,
well,
John,
thank
we
you. I
thank you.
appreciate that.
Yeah, we thank you so much for your time. If you think of anything else you want to add, just please send it our way. And it's good seeing you again.
Likewise, take care.
Bye.
Thanks for the opportunity.
Thank you.